Thank you, Dr. Amr. Thank you, Dr. Walid, for the lovely session. Before we move on, please allow me to thank Dr. Saad and his team for the great effort behind this outstanding course. Also, a big thank you to our eminent speakers for sharing their knowledge and experience. And another thank you to our attendees and for their attendance and their time. Always, it's an honor for me to be among you. Moving on to our next speaker, please allow me to welcome and introduce Dr. Mohamed Mostafa. Dr. Mohamed is a consultant anesthetist in North Cumbria University Hospital. Also, he is the lead of regional anesthesia and acute pain consultant. He's got long-standing history and achievements in anesthesia. He trained in Benha University Hospitals, Egypt, where he achieved the master's degree and the degree of medicine. Then he pursued training in the UK and he got his FRCA and the EDRA, which is European Diploma of Regional Anesthesia, and a scholarship of regional anesthesia from Zurich University, Switzerland. Today, Dr. Mohamed is going to shed some light on a very important topic, which I believe is a daily guest in our anesthetic practice. Sometimes it can be very challenging or tricky, which is the hip fracture. Dr. Mohamed will present today the evidence-based updates of anesthesia for hip fracture 2020. Dr. Mohamed, please go ahead.
Screen around, right. Okay. Thank you very much, Dr. Rabab, for these lovely words, and thank you, Dr. Saad, and all the organizing, scientific organizing committee. I'm really proud of the all hard work done here, and it's my first time to present this fantastic mega academy, which every day it becomes bigger and bigger. So a very, very big well done. Thank you very much. First, there's no conflicts of interest to declare, and taking you out now from the ICU to the trauma theaters. And it's really, I really enjoyed the fantastic presentation by Dr. Reid. I really enjoyed it about how, and one of my persistent worries is how I can implement or be taught about the using of echo and ultrasound as in operating theaters, and hopefully I will learn this in the future. What you're expecting to listen from me today actually is the conveying message about the perioperative care of patients with fractured neck femur. And this is going to happen by reviewing the most recent updates from the association, which actually came out of the press on about, I would say, 10 days back. It's been published in Anesthesia Journal. And also I will go ahead with, have you seen here, the whole bubbles by the COVID language. So the whole bubbles about the conflicts and debates and the standards. And so we'll go ahead again with reviewing some of the evidence-based high quality research considering the anesthesia for hip fracture, which we all at least is facing it every day. So I hope we'll have fun. So my name is Mohamed. I'm a consultant anesthetist in North Cumbria Hospital. This is one of the busiest trauma centers in north of England. And in our anesthetic trauma theater, we're doing hundreds of hip fixation every year to our beloved ones, which could be one day one of your close relatives suffering from significant amount of stress and pain, decompensating their underlying comorbidities and frailty. And actually, these diseases could be a cause of their fall and injury, like, for example, severe valvular lesion, like severe mitral or aortic stenosis, dementia, heart failure, strokes, and even sometimes it could be a bone disease. And by reviewing all of this, you can imagine how much is the important facts about the incidence, and when we realize that it's not an uncommon disease, it's actually happening to a lot of frail and elder patient, and there is different outcomes like what happened with Ronald Reagan and Paul. And it makes a lot of sense when we have a plethora of evidence reiterating the bulky burdens financially, and the poor outcome medically. Personally, I would say undoubtedly that things are getting better here in the UK, a country with high aging population, and I reckon 3 factors contributed significantly in improving the outcome in fracture or managing patient with fractured neck femur. The first is high quality research, and there is no doubt about it. Things like the NHFD, which is a National Hip Fracture Database, which is nationally implemented, and its reports are consolidated to produce guidelines, which is all these guidelines, these spans, the grades of recommendations and standards for us to follow. And this is the second factor indeed. The third one is the measuring your compliance. So you've done all of this work, and then how you are measuring how you are compliant with these standards. And these standards, if met, it results in additional payment and financial incentive to every healthcare organization, which is called the BPT, or the Best Practice Tariff. And if you are not familiar with that, the BPT, or the Best Practice Tariff, at the National Hip Fracture Database, it's available on internet for any healthcare personnel and every member of the public. So you can type down the National Hip Fracture Database, and as you can see here, to the left side, there is number of years which you can open, and then you can see the reports about your compliance to the standards which the country bought to improve the perioperative care for patients with neck femur and reducing their length of stay in the hospital. And again, if you haven't seen this before, so this is actually an example of the reports. If you want, just type down your hospital like what you're seeing here on the left side, and you can see different colors for every standard which is bought to improve the patient outcome. So things like, it's not only about anesthetic or the surgery, it's about the whole multidisciplinary bundles of care which is provided to these patients. So you'll find here admission to the hospital within 4 hours, the mental test scoring. There is a physiotherapy, rule of physiotherapy, nutritional assessment, delirium assessment, mental test score as for delirium, a lot of things. And as you can see from anesthetic point of view, actually here, you'll find that spinal and the general anesthesia as a mode of anesthesia is not included as part of the high standard of care. Actually, the involving of nerve blocks to either spinal or the general anesthetic, it's one of the highly recommended practice for these patients. So you can see here that this dark green to red and dark green, actually this is the best, and the red is the areas to improve for your hospital, which you have to be stick unless you're going to lose your best practice tariff or your financial incentive. So now I'm going to address some of the high quality research, which is I'm going to rely today on my presentation. So we have the ASAP, which is the Anesthesia Spread Audit of Practice and its secondary analysis by Professor Ian Mobbett. And also ECONOF study, there is the hip attack study, there is a Fragility International Fracture, there's a Cochrane Library recommendation consensus about the hip fracture surgery in adults. And lastly is the guideline from the association, which is then blessed to come out to shed some light for the changes on recommendations for patient care, which came out of the press about 10 days. So it's really invaluable notes there. Right. So as you can see here, we'll address most of these standards and conflicts and debate, which is actually according to the previous guideline from the association in 2011. There is some of these standards, they haven't changed much, but some of them, they're a great and significant change, which is really important to know. And the first is prompt surgery, enabling timely hip fracture repair. And I consider this is the most important risk or the most important entity for improving the patient care and get them out of the hospital as early as possible. So based on the meta-analysis, and the 2011 guideline and the fragility network, which they propose that people pragmatically should receive a corrective surgery within 48 hours. But the audit standards of the association at 2020 changed it into a more stringent target of a 36-hour. And why of that? There is no randomicity here. So you have see the 36-hour for a time frame to operate on these patients. Because of every 24 hours, there is increase in 10% of mortality rate. Plus there is twofold increase in delirium and cognitive dysfunction. Actually, in another trial here, which is called the ECHO or the HEPATAC trial, which is actually a large randomized control trial comparing complications rate regarding the admission or the time of surgery between 24 hours. Yes, you can really try it, and 6 hours. 6 hours from the time of admission to the hospital. And they found that there's no difference in mortality rates, 20 days mortality rate between the two groups. However, there is time of mobilization for patients in the 6 hour group, and least delirium has been addressed. Right, this was the first and the most important thing. And the second is something which called delay versus optimization. So when you go in the ward to see a patient on the day of surgery, a patient with fractured neck femur, and you can, in your opinion, that this patient really needs a bit of more optimization and a bit of delay, I would say. So what's the evidence behind this? So we all know all about the 7 acceptable cause of delay in 2011 guideline, which is in 2020 guideline, it became more realistic and more pragmatic in keeping away from the reaction to certain numbers, which is actually I personally hate. So things like hemoglobin less than 8, sodium concentration 120, 125, things like this, it's been moved away and it moved into a general risk-benefit analysis and assessing the patient in terms of all risk which encounter his delay to go ahead for surgery. And it does say, see here very clearly that delay should be therefore on a treatment plan. So if you go and see your patient and you think that there is something to be corrected, it should be a multidisciplinary team management plan and should be reviewed a very small period of time. In every 6 to 12 hours, you should reviewing your correction if it's make a difference for a patient, hoping on the next day morning he go ahead of the surgery and not delaying 2 and 3 and 4 days, which we are facing every day. And actually, I think that personally that achieving an exemplary effective optimization for this patient in most of the hospital I worked in is resources intensive and rely in the way it needs the departments need to have relying on a very well-staffed ortho-geriatrician service to achieve the rapidity and all this optimization. And if you're canceling neck or femur patient, your delay should be contingent to a treatment plan, and this is very, very important. And I would say that there is often little that can be effectively optimized while patients remain in pain and immobility. Right, moving now to one of the most important standards, and I think this has made a major change from the 2011 guideline. It's very relevant to our anesthetic practice, which is the usage of the antiplatelets, the anticoagulants, and the spinal anesthetic. We have to be careful here. We have to be very careful here, guys. So bear with me here, because actually the guidelines which you are familiar with about your anticoagulation and neuroaxial anesthesia, you have to stick into it. Keep sticking into it, especially when it comes in a treating patient with conservative approach and a safe elective case. Things like total hip, elective total hip, patient he's not urgently need to go ahead, like patient with neck of femur or elderly and need to be going ahead next day. So you stick to your conservative and safer approach of perioperative management of neuroaxial anesthesia under anticoagulation. However, the association did mention here that if you have a patient which is expected to be delayed because of the usage of anticoagulant antiplatelets, especially the new direct anticoagulant drugs, which is reported out, if my memory is about 30% of patients has been delayed more than 36 hours in the UK because of the direct oral anticoagulants, you go ahead for general anesthetic and blocks. And when the general anesthetic and blocks is dangerous, or the spinal anesthesia is deemed superior to the general anesthesia, like an example, for instance, severe chest disease, and you are adamant to go ahead with a spinal, so go and read and stick to these guidelines here on changes about usage of anticoagulant in patient with neck femur fracture. And the first thing is antiplatelets and dual antiplatelets. So, So single antiplatelet, including clopidogrel, is not a contraindication to spinal. Even more than that, there's dual antiplatelets, or patients who are taking dual antiplatelets, like for example, aspirin and clopidogrel, for who are unsuitable for GA on a risk-benefit analysis. So if you go and see your patient and he is on clopidogrel, I would fully, and you need that, you see that this patient is high risk for general anesthetic and you want him to have a spinal, you don't delay the surgery. You don't delay the fracture in femur for 48 hours and 30 and 3 days and taking the surgery further and further delays. So you go ahead under what we call a risk-benefit analysis. You have to describe it as a team. It's not only you, as a team, to the patient and to the relatives. And you fully explain all the risks. And you go ahead with the surgery, because it's the other side with the high mortality and morbidity secondary to delaying surgery. Second thing is patient who's taking warfarins or vitamin K antagonist. So it's stated clearly, and I don't think that this is not changed much. So you can operate with the INR less 1.5, and you aggressively reverse the anticoagulant since the admission to the A&E or the AR using the vitamin K with 4 to 6 hours intervals and prothrombin complex concentrate until the patient is ready to go for surgery the next day. Another thing is the bridging therapy. So the bridging therapy is not contraindicated unless the patient have a more complex thromboembolic management, like patient with metallic heart valves and patient who are having a renal dysfunction, direct oral anticoagulant reasonably unprotected to go ahead with a spinal anesthesia after 2 half-lives have elapsed. An example for this, which is really, really nicely illuminated here about dealing with direct oral anticoagulant, things like rivaroxaban and apixaban, which is you need. I remember we stayed about 48 hours or even sometimes you wouldn't really go ahead with a spinal, or you wait for some guidelines even more than that, 72 hours. So now with this new guideline does say that if you creatinine clearance more than 30, proceed 24 hours after the last dose, and if less than 30 ml per hour, you measure the factor 10. For thrombin inhibitor, things like the dabigatran, so you measure the thrombin time at 8 o'clock in the day of surgery, and if the thrombin time is normal, you go ahead with surgery. If the thrombin time prolonged, you have to liaise and contact your hematologist and consider the specific reversal for the dabigatran if it's available in your institution. And frankly speaking, considering this point, I would say that there are 4 factors, and actually it's not 4 factors, there are two parts here. The first is you worry as an anesthetist, and me is the same. It's all the legalities about the surgical view. All of us, we get worried about non-stopping of or operating under dual antiplatelets and under patient with anticoagulant because of fears of surgical bleeding and because fears of vertebral canal hematoma, okay? On the other side is if you abruptly stopping your anticoagulant, you're exposing the patient again into thrombosis, and thrombosis can happen to to his stent. If he's having a stent in his coronaries, has a thrombosis in his any vascular disease, is a thrombosis in his carotid and CNS, etc., etc. Plus the major risk of delaying surgery and increasing morbidity and mortality. It's not by instant just on the day of surgery, it could be later on. And actually, most of the orthopedic articles, I've read it all, they are all more, liberal in and go ahead under umbrella of antiplatelet if the patient is underplatelet or anticoagulant. And they found that there is slight increasing actually of perioperative need for blood transfusion, and there is no increasing in mortality rate. And we all know the NAP3, which in the UK, which is dealt with all the major thromboembolic and anticoagulation effect with neuroaxial. And it showed that the incidence is 1 to 118,000, which is incidence actually also became less likely to happen in geriatric and frail patients with fracture neck fever. So all these things should be kept into consideration when you assessing patient with fracture neck fever. It's not easy. I know it's not easy. It's something sometimes make a lot of dilemmas and a lot of debates. So you have to consider dealing with this patient on and very frankly multidisciplinary access and pathway. Right. Moving in now into, I would say which one, Babel? Yeah, GA. So this is a GA versus neuroaxial. When you're dealing with a patient with fracture neck fever, which is better? Are you going ahead with a general anesthetic, or are you going ahead with the neuroaxial? Which one is better? So association or an association 2020 guideline and the ASAP trial did mention it clearly that there is no convincing evidence that either regional or general anesthesia is superior. So whatever you're familiar with, use it. So whatever you're familiar with and whatever you see that the patient outcome with your very good spinal anesthetist, you do a very good spinals, very good GOGs, and your blocks are fantastic. So whatever you're familiar with, use it in these patients. But however, what's more important is avoiding hypotension. What's really killing these patients is lowering their blood pressure more than 10 minutes. So you have to keep the blood pressure. Whatever you're using spinal, whatever you are using your general anesthetic, so you have to keep the blood pressure more than 80 millimercury, the MAP more than 80. And I personally have a very low threshold for using arterial line as an invasive for managing this patient and using a background vasopressor infusion. And yeah, if you're doing your spinal, also use the lowest doses you can do to cover the surgery. Things like more than 10 milligram, not more than 10 milligram of bupivacaine, that's more than enough. And also, for example, the thing which we are going to describe later is the measures to prevent bone seam implantation syndrome. Although that the fragility, I know that there's some people saying that the fragility network and the Cochrane reveal that the neuroaxial is slightly better in terms of thromboembolism in absence of pharmacological measures, but the whole picture and the whole evidence does say about the mortality rate and the perioperative outcome. There is no convincing evidence which one is better. Right. Next is the anemia and blood transfusion. And then is again one of the things which is being debated. There's a perpetual conflict whether you are giving blood with all of its side effects or you're leaving anemia with all of side effects. And the evidence does say here, according to the 2020 guideline, is that the target of 9 grams should be adopted for frail patients. You don't reduce it less than 90 or less than 9. The target increased to 10 in case of ischemic heart disease, and this makes sense. Cochrane showed also that there is no clear benefit, either restrictive with 10 gram deciliter or liberal with 8 gram deciliter on transfusion threshold, and a sign of lower quality evidence of lower risk of MI in the liberal group. This was anemia. Second standard is about undiagnosed cardiac murmur. This is very important again, and I think this is one of the things which we all relying, which asking echoes, and asking echoes could delay your patient to go ahead with the surgery. And according to what we call the ECONOF and the 2020 guideline, so echocardiogram is a very invaluable tool to diagnose cardiac murmurs, to diagnose valvular disease, and to know what's the regular wall motion abnormalities and blah, blah, blah. So, but it's as a cause of delay by asking echoes, this is unacceptable, and this should be abandoned. So if you have the ability in your institution to do the echo on the same day, or you do the echo within the first 2 hours, to go ahead, if you think that this is going to change your anesthetics, so go ahead and do it. That's fine. It's perfect. But if you don't have the facility and you think that the patient needs to move to another hospital, or needs a lot of legitimate points about referrals and delaying of doing echo the next day, this is not acceptable. And we are knowing ahead that according to the 2011 guidelines, the waiting echocardiography is one of the unacceptable events. And actually, it makes a lot of sense for me. Right. Proceeding with surgery with anesthesia and surgery. And I think this is again one of the important points. And there are some patients, when you go and see them in the wards with a fracture neck femur, with a lot of comorbidities, with a lot of frailty, they look to you, they are not fit for surgery, and they're not feasible to go ahead with surgery with them, even if it's palliation or a palliative surgery. So this dilemma now is whether to proceed or adopting an approach which is called non-operative approach, or palliation. Palliative care means that if this patient receive a conservative management, you keep him unfixed, you're exposing him to pain and immobility, which is inhumane. Inhumane. So what the guideline did say, according to Johansson colleague and the same group, which is the 2020 guideline, they found that although the excessive mortality, this patient who didn't undergo surgery, they have a 48.6% mortality rate compared to 6.6 patients who have the surgery. And I know this is a lot of bias here, because actually the patient who didn't have the surgery, they have advanced frailty or significant advanced disease, which make them not suitable for going for anesthetic. However, if you read the article, it did say that a patient with a mortality rate was 24.8% in patient with ASA 5. So if we assume that all non-operative patients with ASA 5, that's still a very large, big difference. So I would consider, please go ahead, even the patient is deemed unsuitable for general anesthetic, unless the patient actually is dying, or he's immediately going to die within 24 hours or 48 hours. Right, I think I hope that does a lot of make sense for all of you. And I think this is all the scenarios which we are going ahead every day. Now, the bone semen implantation syndrome, another standard, another things which you have to be available, and this is out of the context of speaking in this presentation here. It does have a separate presentation, but I will go for general points, identifying the risk factors and preparation for the team. It's very important as a part of non-disciplinary. And if you're identifying patients who are liable for having a bone semen implantation syndrome during your hemiarthroplasty or total hips, you have to consider briefing this patient in the timeout checklist. And for you, there is certain steps, things like adequate resuscitation, being vigilant during the time of cementing, maintaining systolic blood pressure, etc., etc. So this is the bone semen. Then the peripheral nerve blocks, and actually the peripheral nerve blocks and regional anesthesia, and this is one of my favorites part of but unfortunately we're not going to details about how we can perform and what's the performance about the regional anesthesia. But I think, guys, for anyone who's practicing regional anesthesia, for anyone who's doing a relevant regional anesthesia technique for specific surgery, it's a mandatory as Dr. Walid said in the last presentation, it's very important to be taught correctly. It's very important to know the anatomy. It's very important to practice at a junior and do excessive knowledge before reaching or holding your probe. And things like hip fracture or hip capsule, it's very important to know the anatomy or the innervation of the hip joint, because actually any joint, shoulder, hip, knee, they are having a complex innervation because it's not as simple as we expect. And there's still, until now, there's a lot of research going on to understand what's the perfect innervation of different joints. But it's undoubtedly there is the innervation of their joints coming from two plexuses, which is the lumbar and the sacral plexus. From the anterior part, there is muscles, there is ligaments, there is intracapsular ligaments, there is extracapsular ligaments, there is bones, there is what's called osteotomes, and there is the skin, which is relevant for every type of surgery. So the lumbar plexus and sacral plexus, and we have from the lumbar plexus the major contribution here, which is the femoral and the obturator nerve and the lateral cutaneous. So the femoral does have a major contribution, and I cannot really imagine doing a hip surgery without blocking your femoral nerve, because it does a big difference. It does have a major contribution. For every joint, there is like a star nerve. You know, something like, for example, if you're doing the shoulder, there is a suprascapular nerve. If you have the knee, there is having the saphenous, there is have here is the femoral nerve. And the femoral nerve does have a major contribution to your joints. Obturator, lateral cutaneous is not for the joint, it's only for the skin of the skin incision, which is also very important. And if we go inside the joint, there is posterior part, which comes from the sacral plexus, things like the sciatic nerve, superior gluteal, nerve to quadratus femoris, etc., etc., and posterior cutaneous for the thigh, for the skin. For the intra-articular anterior hip, there is femoral and obturator, and there is another nerve which we'll speak about them later, which is accessory obturator nerve. So which blocks you will do? Which blocks will you choose? There's 10 blocks. Every day, we've been flooded by numbers of different recent blocks. And I know that all of us, we are very enthusiastic about doing blocks. But femoral blocks still the more fundamental block we have to learn, and we have to include it as part of our multimodal analgesia, which is useful as both opioids and non-steroidal have a greater potentials to cause harm to elderly frail patients. So the femoral nerve is very important at this point. And when you're doing the femoral nerve, it's not only a simple femoral nerve like what you're doing for normal a leg or a thigh operation. Here you need to understand the anatomy, and you know which branches come out of the femoral nerve to innervate the hip joint, which is quite higher than the normal. So we have to go up above the inguinal ligaments to get all the innervation of the hip joints. After the femoral nerve, there is another nerve here, which is the lateral cutaneous, which is one of the most important, again, nerves to be blocked, which could be blocked solely, or which could be blocked as a part of 3-in-1, as part of your fascia iliaca to block or to cover the skin covering the incision site. Again, the star of anesthesia for hip. This is a star block. Guys, I think it's very important now. Now the fascia iliaca, whether it's suprainguinal or infrainguinal, whether it's suprainguinal or infrainguinal fascia iliaca block is a national standard. It's something to be done for every patient, either as a single injection. Actually, in our hospital here, we're doing it, and this is the national standard. Every patient with fractured neck femur, when he comes to the A&E, he get the block by the medics, or he got the blocks by the A&E doctors before he going up to the ward, because big is a big difference by ultrasound or even blind technique. And there is an infrainguinal and the suprainguinal approach, and it's something which is, I think, we need to learn it, and we have to include it as one of the bundles of care giving to these patients. So I'm just, don't know that the video is going ahead here, but just having a video from our
infrainguinal approach. The first one here is the infrainguinal.
So this is what you can do, the sartorius, and this is the psoas muscle. And I think that this is something.
Femoral nerve is beneath the fascia.
So the femoral nerve.
And the femoral artery beneath the fascia lata.
Yeah. I'm not going to show all of this. So this you need all this is for infrainguinal. So if you want to block or use it.
And underneath the fascia iliaca, open to see the local anesthetic spreading towards the femoral nerve spine, pointing towards the umbilicus. Sliding along the.
So this is the suprainguinal, using the anterior superior spine, and then you can have
the overriding iliacus muscle. Yeah. Inferolaterally, the sartorius muscle is seen, and superiormedially, the abdominal muscles are also seen. The needle is brought from an inferolateral position, aiming to pierce the fascia iliaca above the iliacus muscle.
Right. So this is the fascia iliaca block, and actually after the fascia iliaca block, there's others. Actually, there's other types of blocks, and I know that there is a number of blocks. Every day we have different type of block, and nowadays we have fascial blocks, things like Bing block, and I think people get used to use their names as standard for these block, things like ASP, quadriceps lumborum, you heard about this for using for hip fractures. All these blocks are fine. Obturator, sacral plexus, never be used alone, should be combined with the lumbar plexus, or we could combine with the femoral or fascia iliaca. QL, ASP, they are all these blocks still under research. It's still case series. So please, guys, stick to the standard research, standard high quality a clinical practice of anesthesia, of regional anesthesia for patient with fracture neck femur. So don't use this block unless we get a plenty of evidence, even including what we call the Bing block. The Bing block, although that we're still on the beginning, but this is one of the promising blocks which has been introduced recently over the last 2 years by Toronto group, and it was mentioned here by Philip Bing. It's actually called pericapsular nerve group block introduced by Bing block, so it's called Bing block. And the reason for choosing this block is about considering blocking the femoral nerve and obturator. They found that there is high variable innervation above the inguinal ligament and below the inguinal ligament, was 100% they found above the inguinal ligament from the femoral and obturator, and another nerve is called accessory obturator, 100%. And actually this makes a lot of sense of the high efficiency of the suprainguinal fascia iliaca, because actually most of the femoral obturator suprainguinal is in a percentage was found in specimens in 100%. And there is also the high branches were 554 and 31.4 obturator. And also there's low branches followed by 7.7 and obturator below the inguinal ligament. So this is something which is could be used in the future. To block the articular branches without mobility or selective blocking of the articular branches. And it's quite easy. It's quite easy using curve probe. And actually, I would consider it as easier than the fascia iliaca, blocking at the level of the iliopubic eminence and anterior iliac spine. But bear in mind again here that when you start to learn, you start to blocking, or you start to choose a block, consider this could be one of your close ones. So don't use with your mom, your dad. So don't use a specific new type of procedure unless we have plenty of evidence about using it as a national standard or as a worldwide standard. So this block, by understanding the anatomy, and you see here, it doesn't cover the large cutaneous, so it cannot be used for complete anesthesia or analgesia for the surgical side. So again, it's less for myself. It could be very good for ambulation, very good for day in surgery, but it's not enough for, you have to combine it with other nerves to have the same effect from the fascia iliaca or the femoral nerve block. Right. Then we have the delirium, and delirium, it's all of us one of the most common determinant factor which increase the length of stay of this patient in the hospital. So it's very easy by sticking into the standards we have all mentioned, by timely surgery, prompt operation within the 36 hours, avoiding hypotension. Be friendly in dealing with elderly, especially when it comes to the pharmacological agents like central anticholinergic drug, avoiding things like the atropine, cyclizine, chlorpromazine, the sedatives like the benzodiazepines and ketamine, all these drugs which could be contributing to causing acute cognitive dysfunction. Also avoidance of blood pressure down, or avoiding, sorry, of hypotension, which can cause brain hypoperfusion, and avoidance staff education about how we can deal with a dementic patient. And that's why actually we do prefer not to admit this patient unit unless they really strong needs, because actually the atmosphere and the noise in the unit and all this can precipitate acute cognitive dysfunction in these elderly patients. Right, I think we reached the end here. But before I ending my presentation, this is a very nice presentation about another table about different types of procedure, which is actually cannulated like the DHS or cannulated head screws, and it can give you an idea about, and there's a courtesy here goes to the BJ Education article. It's very nice anesthesia for hip fracture. And it does have a lot of things like the typical incision time, the positioning, and what's the average. So you have to challenge your surgeon about his time, surgical time. Also, you can see here, so this is here my recipe, and I leave it here. But again, please guys, do whatever you're familiar with. You don't stick to certain procedure and you get, but it's something which you could give you some idea about other people, what they're doing. So for personally, I'm a GE person. I don't do much spine unless I need it, but I include blocks for every patient with fracture femur, and the blocks done awake. And this is the first thing to do when the patient arrives to theater. We have a service of continuous catheter, and the continuous catheter starts for fascia iliaca block, continuous catheter, which starts since the patient comes from the A&E or he has a single injection. So you have to time gap about 6 hours until you do your second injection or second bolus. The fascia iliaca, you all know it's a facial block, so you need to give a large volume flow anesthetic, plus or minus 40 ml of Lidocaine 0.25%. When the patient arrives to theater, lines, fluids, and I give Lidocaine 2% to the femoral, 10 ml Lidocaine 2% to the femoral laterocutaneous, and then I give the fascia iliaca, and then I have very low threshold, as I mentioned, to arterial line. Variable rate of vasopressor could be on the background, bitramonol, like that's happening here in the UK, or phenylephrine in your hospital. I don't give any morphines. I use short-acting opioids in induction, and most of the GAs are LMAs. If I'm using the spinals, I do block again awake, again Lido 10% ml Lidocaine 2% to my femoral laterocutaneous and fascia iliaca later on using Lidocaine, and I go on scrap, okay, and do my sterilization preparation. It takes about 5 minutes. So your block is going to be working at this time, shifting the patient with surgical side down, and again I don't give more than 10 ml or 7.5 to 10 milligrams of heavy Morcaine. And I keep the patient for 5 minutes for lateral position. Again, there is no opioid in the spinal and no sedation. I don't use any sedation. If it's required, could be the option of TCI propofol. And again, this is something which is don't force yourself to use it if you have your own way of doing things. And I think most of you much better than me. So you just take whatever you are familiar with. As I said, there's little evidence that the general original is superior than each other's. What's really important, and what we have to reiterate again, and we do mentioning here, that it's very important, guys, for adopting, usually always follow the evidence-based approach for patient with fracture neck femur. Fracture neck femur is one of the 6 patients in the hospital. Is very critically frail. He's having a lot of this. He's one of your could be one of your close persons. So you have to give a very excellent and very type of anesthetic which fitting into these frail patients. Implement strategies, avoid hypotension as much as you can, and taking all the precautions to avoid delirium, especially, is common to happen in the recovery. Timely surgery and using multimodal analgesia, and play your part. Please play your part as you're from the multidisciplinary team. I think if you get all this under, you will have a very lovely patient. And believe me, actually, I like to go and see my patient in the ward after finishing, and it's if you are following these type of perioperative approach, and if you have an excellent team, it's not again about your surgery or about anesthetics. You are playing a part. You'll find your patient the same day of surgery out of the bed, eating and drinking, and his compass mentis. He's just communicating very effectively with all the surroundings. And I think it's really deserved, because it's really a burden, high burden onto any healthcare organization, and they have a very long health of stay if you don't follow these recommendations. So I hope we all enjoyed this lecture today, and thank you very much.
Thank you very much, Dr. Mohamed. Really, that was very comprehensive. And as I said in the beginning, this is a daily encounter. We see this every day. So I believe this lecture will be very helpful to all of us. And what you said is part of the enhanced recovery package. So it was really, really informative. I've got loads of questions for you. So I will start with Mohamed Abu Said. Any experience with hip surgery under peripheral nerve block as the main anesthetic? Right,
okay. So, as I mentioned, there is some case reports about peripheral nerve blocks alone, and if you, Mohamed, if you see the highest complicated innervation of it comes from the lumbar plexus or the sacral plexus. If you are experienced, do lumbar plexus block or sacral plexus combined both together, go ahead. But I would consider why the patient is exposed to amount of stress and you turn them to the right and go to the back while you have a very easy spinal or a GA and very good perioperative analgesia and playing with your knowledge about understanding for the nerves. I think this is more than enough. I've read some articles about doing peripheral nerve blocks, but for myself, I never done it. I keep it very simple, keep it very safe. These patients are very fragile. They don't, the more you're exposing them to a stress of surgery and stress of new techniques of peripheral nerve blocks and things alone with sedation, it's going to make a lot of troubles. But I don't find a reason why not you doing GM blocks or spinal blocks and taking into consideration all the other factors like the hypotension, which is actually I consider is the most top standards of your perioperative anesthetics.
Right. Another question from Mohamed Abu Said. He says the patient is frail with severe aortic stenosis. He is likely to die from anesthesia, and the MDT decision was to abandon the surgery. I'm not sure, is this a continuity of the previous question, or is it another question? So. Yeah.
So I think with a patient with aortic stenosis, it's not uncommon in patient with if you're doing it's aortic stenosis shouldn't be a cause of not doing surgery by itself, but there will be, I don't know if there is any other cause, or the patient is very, very frail and sick and ill. As I mentioned in the presentation, the new recommendation is clearly documenting that leaving patient non-operatively or you adopting non-operative approach, you are exposing the patient to like a trial of death. So he's going to die from staying at bed, from bed sores. You don't adopt a non-operative approach unless the patient truly dying, the patient having a very, like for example, patient with severe heart failure or he is a dementia. And we know here in the practice in the UK, there is something called the do not attempt resuscitation, DNA CPR, and end-of-life and palliation care, which you will consider these teams to intervene if you are thinking that this patient is actually dying. And again, at the end, it's, as you mentioned, Mohamed, it's a part of multidisciplinary team. It's a part of your decision or the whole team together. But you have to stick to what's been recommended in literature about the fate of this patient. And I personally, and we've seen a lot of my colleagues, they do a pain management and a continuous nerve block for patient, and they don't do surgery for them. But believe me, it's inhumane. It's something which should really, really feel like exposing them to a very high amount of stress and if you are adopting non-operative approach.
All right, thank you for that. Another question from Mohamed Salim, a patient with lumbar spinal fusion, how neuroaxial blocks achieved in such patients for hip fractures if it is the only anesthetic technique? I don't know.
I don't understand. If you mean like the patient with lumbar spinal fusion?
Yeah, I think.
Yeah, so if he means that, Mohamed, if he means that you have a certain abnormality in the spine, and you think that this is difficult, this is something which is, again, if you think that you cannot put a spinal or stick a spinal in this patient, you have rules like the ultrasound, which you can scan the back, and you see if it's feasible to go ahead. But this is not a contraindication again for not giving a spinal. And if you feel like it's difficulty, if this my patient, I think that this is a very difficult spinal, I'm going ahead with a general anesthetic. So what's the problem? So general anesthetic and blocks.
All right, next question from Hilal Siddiqui. Lidocaine, is that suitable for spinal as a spinal anesthetic for fracture neck of femur surgery in high-risk elderly patients, and what is the safest dose?
Right, Hilal, thank you very much. This is very good. So yes, definitely any short-acting local anesthetic could be used for, but you have to be first familiar with it. You surgeons, because you have to be very careful. If you are doing a hemiarthroplasty under spinal, or you're doing DHS, and you're expecting that 95% of your surgeon doing the DHS within an hour or within 45 minutes, that's fine. But if you're expecting that your surgery is going to prolong, just use a standard local anesthetic, like the helimarcaine or the Lidocaine, or levobucaine. Some of the people here, they're using levobucaine with a surgical side up, 2 mil again, or 2 to 3 mil of local anesthetic. Honestly, Hilal, I have no experience with using the Lidocaine in my spinals and hip fractures, so I cannot give you the exact dose of the Lidocaine.
Right, next question from Mohamed Abu Sayed. Any evidence of leaving a nerve catheter with elastomeric pump? We use this for knee surgeries. What about hip?
Right, very good. Okay, so Mohamed is again, the patient with fractured neck femur, the worst painful stimulation, and the worst part happens when the patient gets a fracture and he going to be moved to the ER in the hospital, using the ambulance, and then moving up to the ward, and then caring of the patient in the ward until he comes the second or the third day to theater. So the worst time the patient exposed to pain is the preoperative part. So if you are putting a catheters, and that's what's happening in our institution here, we put a catheters for fascia iliaca or femoral block when the patient arrives to theater, not leaving, because actually the best modality of treatment for patient with fractured neck femur is their surgical fixation. So when the patient gets fixed and they got a block bolus in theater, I think that's more than enough. And I will use short-acting opioid and paracetamol, and that's it. Also, you have to understand, Mohamed, about what type of nerve blocks you're using. So if you have a patient coming on the day of the trauma, or he has a fresh trauma, I would do a femoral nerve block, high approach, because actually you don't need a lateral cutaneous, because lateral cutaneous you need it for surgery. So if you're expecting the lateral cutaneous to be, you're expecting the surgery to happen next day. So why are you blocking the lateral cutaneous in the first day? So you block the femoral. So you be interested in blocking the femoral the first day. And put a catheter if you need, like a femoral nerve block catheter or a fascia iliaca block catheter. It's very excellent, very excellent service. And then you can bolus it. So what we do, you will bolus it when the patient arrives to theater, and then take the catheter out. We don't leave the patient, we don't send the patient to the ward with catheter to help them to ambulate and getting out of the bed.
Okay, another question from Mohamed Abu Said also. Experience with plain chirocaine with the fracture limb?
Yeah. So it's fine. You can use the plain chirocaine, but this is not depending with the parasite. So if you are placing your local anesthetic, so there's some of my colleagues doing this, it's absolutely fine. You can use 2 to 3 ml of chirocaine, 0.5%. In your spinal, and you get your surgical side up rather than down, and this is absolutely fine. It does work and perfect. But personally, I use normal heavy marcaine with surgical side down, as I mentioned with my blocks.
Thank you for that. Ahmed Fakir, at any level, we do the ESP block for hip surgery.
Right. Answer of this from me, I don't know. So ASP blocks for lumbar for hip surgery, there is few evidence. I know that it's something, it's eminent. People are very interested about trying ASP in everything, all type of operation. We do an ASP blocks for rib fractures, which is really having a big evidence, but using an ASP for hip surgery, it's going to be a lumbar level. So you have to bear in mind that this is the ASP and the ASP block at the lumbar level is a kind of deeper block. So you need a bit of experience in doing them and properly putting the local anesthetics very deep under the rectus spinae. But I personally, I'm very simple. I like to do a standardized nerve block, which should really make a big difference. So I don't find a reason why we have to change or why we to switch to another advanced, deeper block, especially when the patient under neuroaxial. Why you would go to the deeper block, the lumbar plexus or ASP, while you're having a very superficial, while the patient supine. So your patient is supine. So you're doing your block, you keep him out of pain and do whatever you want. So please, guys, just try to be mastering the easy and the standardized ways of nerve blocks.
Yeah, I do agree with that. Next question is from Mohammed Ahmed Ali. Could we give intrathecal lidocaine 2% instead of heavy marcaine for spinal anesthesia?
No, I don't think so. Also, it's not something related to preservative. I don't use lidocaine 2% in spinal. No.
Right.
I don't use it.
Ahmed Siam, any role of continuous spinal anesthesia in such fragile, especially if surgery time prolonged?
Right. Okay. Continuous spinal anesthesia in such a fragile patients. I don't find a reason why not to making it, or you expecting a patient with but practically speaking, I don't know whether the continuous. So if you're expecting someone who having things like hemiarthroplasty or DHSs or gamma nailing, what sort of time duration you are looking at, and why not, if you are expecting from the beginning, you are expecting that you have a general anesthetic, why not you put patient you on the general anesthetic LMAs and expose them to less stress and hemodynamic instability? But from I don't know, just I think it's no contraindication for that if you're using continuous spinal. But again, this is something which is I have never used it in patient with fracture neck femur. I use very standard GO blocks or spinal blocks, and if your spinal wears off, you give an LMAs, or if you're expecting a special type of patient, you can do spinal epidural, combined spinal epidural rather than continuous spinal. But this is the thing which is I consider it's a safer approach to have like a standard ways of management.
Next question from Ahmed Mohammed. Can we use plain Marcaine with a fracture site up?
Yes, yeah, I did mention this, yeah.
Okay.
This advantage.
Yeah.